actually, interestingly, is the topic of post-stroke anticoagulation, where anticoagulation becomes necessary because of atrial fibrillation as etiology of a stroke. So these patients get anticoagulation. The problem is, what are the patients that will get a further stroke, let's say an ischemic stroke, or what are the patients that will get hemorrhagic strokes? So these are some topics that we worked on it quite intensively in the last few years, and there are some interesting results also on that. But keep in mind, it's really now, in our days, the standard of care to prescribe NOACs and not further to prescribe vitamin K antagonists, as they are first easier to take, B, the NOACs induce a lower number of intracerebral hemorrhage, but not zero, and by increasing number of patients getting this medication, we are awaiting some increasing number of intracerebral hemorrhages, and that's exactly why we did the TEACH-NOAC trial.
Yes, and in addition, one interesting development is that more and more, besides clinical parameters being used to define which patient is treated how for secondary prevention, more and more imaging measures are being applied, also to try to calculate the potential risk regarding recurrent stroke on the one side, but intracerebral hemorrhage potentially related to the treatment, to the oral anticoagulation on the other hand. And these imaging measures are being studied in different studies currently, also in larger collaborative studies. I would like to mention the MICON collaboration, the Microbleeds International Collaboration Network, which studies the implication of markers on imaging related to small vessel disease, especially cerebral microbleeds. So the question is whether the presence of such microbleeds may influence the risk of stroke versus intracerebral hemorrhage. And there is a lot going on, and some of the data have already been presented and also presented at this conference just these days.
This may actually, time is probably at the present time not a resolved issue, as it's a long-term treatment, and it's said once you have found atrial fibrillation, patient will be on anticoagulation even if there's no atrial fibrillation measured in the future. So this is not resolved at the present time. So it's a long-term treatment that should not be stopped. That's one point. So over time, so with life, there is an increasing risk of having either new ischemic strokes or new hemorrhagic strokes. And what we realized in the database that we analyzed is that patients who have a burden with atherosclerotic disease are more likely to have ischemic strokes while being on anticoagulation with NOACs, while patients with microbleeds, and that exactly comes also out from the MICON study, as well as from our analysis of our registry, is that patients on microbleeds with higher number have a higher chance to get a bleeding. So, and this is, of course, it accumulates over time.
And regarding timing of initiation of treatment after stroke, this is still a very important question. Balancing the risk of trying to prevent recurrent stroke versus acute ICH following stroke. But this is also not yet resolved, and I would like to mention an ongoing international multi-center trial headed by our colleague Professor Fischer from Basel. It's the ELAN trial, this study exactly addresses this question on the ideal timing, early versus late initiation of anticoagulation in patients with stroke is specifically related to atrial fibrillation and oral anticoagulation. So these are important questions, and hopefully in the near future we will have more data on these questions also.
Being on anticoagulation therapy is a contraindication for thrombolysis. But you can thrombolysis if you can show in the lab that there is no therapeutic effect of the NOAC, or a very low therapeutic effect. Otherwise, what will come up is to give a reversal agent. But what you can always do is, also being on anticoagulation, to do endovascular treatment. Of course, this will for sure also be an issue for further studies, but it's quite the standard of care to give EVT or to perform EVT to reopen arteries while the patient is on anticoagulation. And then it's clear you will not add other anti-thrombotic drugs in the further treatment, but keep the anticoagulation going, or wait, or then running out the anticoagulation and restart with the treatment according to the results that we are waiting for from the mentioned trials. Yes, but that's a critical issue: stroke under anticoagulation. And we know from our data, many of these patients have quite a high atherosclerotic burden, and they will need also further, for their further life, they will need antithrombotics in any way, in any kind.
Yes, maybe just adding regarding the secondary prevention. Of course, the question arises why the patient experiences stroke potentially under oral anticoagulation, if this is the case. And then we always have to look for the stroke mechanism. So not all strokes, even in patients with atrial fibrillation, are actually then related to atrial fibrillation, are cardioembolic. So it's always the question of the stroke etiology. And these patients need very, very thorough workup to define the stroke etiology, and then potentially in the future modify the antithrombotic treatment. And also addressing these important questions, there are some initiatives and studies going on right now.